Good morning, everyone. I'd like to thank you for joining us today for the Medicaid Home and Community-Based Waiver Service Definition Training. When we posted the registration for this webinar, we did include the presentation and the programmatic change documents. There have been a couple updates made to the presentation that was originally posted. I removed a couple duplicate slides and included an additional slide. So you will see, if you're following along with the originally posted document, you might see a couple small changes. When we post this recording this afternoon, we will post the updated presentation, so you will have that updated copy then. Also, we encourage you to please submit your questions throughout today's presentation via the chat. When you do that, please send that to all panelists. Due to the time constraints and the amount of information that we're sharing, we will not be answering those questions in real time. However, we will be providing a question and answer document that we will post on the division's webpage. It will also be posted with the recording that I previously mentioned. Obviously, that question and answer document will not be available this afternoon like the recording. However, we will get that to you as soon as possible. So again, this is being recorded. It will be posted, and we will send out an email blast letting folks know when that question and answer document is ready. And with that, since we do have a lot to cover today, I am going to turn it over to the first in our list of presenters today, Emily Lubering, who is the Director of the Federal Programs Unit.
Hi, good morning, everybody. Thank you for joining us today. We have a lot to cover, and I wanted to start off by kind of giving an overview of the waiver renewal process. The Home and Community-Based HCBS 1915C waiver applications renew every 5 years, and the last comprehensive and community support waiver applications were approved by the CMS effective July 1 of 2016 and were set to renew in July 1st, 2021. The actual waiver renewal process starts several years in advance of the renewal date, and I'm going to provide a quick overview, a high-level overview of that process. And then, of course, the CMS approved the community support waiver on September 22nd, 2021, and the comprehensive waiver renewal was approved on September 24th of this year, both with an effective day of July 2021. And the Partnership for Hope and the MOKIDS, or the Missouri Children's and Developmental Disabilities Waiver amendments to align with the renewals were approved by CMS on September 22nd, 2021, with an effective day of October 1st. So those are a lot of dates to remember, and we'll be going over more information about those dates throughout this presentation. And we realize that there will be some transition required for the changes, and a letter will follow this, this training to come out this week about some of those transition periods. The waiver renewal process. We started the actual renewal process several years ago, and the process was started in 2017. The Division of Developmental Disabilities brought together a group of stakeholders, including individuals and family members, named the Services Advisory Team, and this team was brought together to consider developing the process for upcoming renewals. The group included individuals, family members, members of MARF and MAC, the DD Council, UMKC, MoHealthNet, and the division. In June of 2019, CMS requested evidence request reports for waiver performance measures, and the Federal Programs Unit submitted the information for those performance measures. The beginning of 2020, the Federal Programs Unit began preparing waiver application documents for program leads to review. Further in July, draft waiver renewals were posted on the DD website for 30-day public comment, and we also had 3 public forum webinars that were held by NASDs. In December of 2020, MoHealthNet posted a 30-day formal public comment period. And then early 2021 in February, MHD submitted the applications to CMS, followed by communications between CMS and DD to answer questions regarding the renewal applications. March of 2021, CMS sent their first round of informal requests for additional information, and in May of 2020, CMS sent a formal request for additional information. In June of 2021, CMS granted a temporary extension for both the comprehensive and community support waivers in order to provide the state with additional time to respond to CMS formal requests for additional information and make all revisions to the waiver renewal application that were necessary for CMS approval. This allowed the state to continue operating both waivers through September of 2021. And then, as I mentioned, in September 22nd and September 24th, we received our approvals for our waivers and amendments. So that was just a brief overview of all the time involved in the renewal process. This next slide is resources for all of our providers and individuals and families. The resources listed here are the applications, the links to the applications that were renewed in this period. And now we'll turn it over to the home delivered meals.
I'm Wanda Crocker, and I'll be talking about the home delivered meals service definition. This is a brand new service definition to the permanent waiver. It might ring some bells for you all as it is currently a part of our Appendix K. Home delivered meals means the preparation, packaging, and delivery of meals to individuals who are unable to prepare or obtain nourishing meals. The intent of home delivered meals is to allow individuals to remain in their natural home without paid staff who would not otherwise be able to without the delivery of meals. A full regimen of 3 meals a day shall not be provided under the HCBS waiver. The provision of a home delivered meals is the most cost-effective method to ensuring a nutritiously adequate meal. The goal of the home delivered meals service is to supplement, not replace, the local home delivered meals services provided at no cost. Home delivered meals must be in lieu of paid staff. So a little bit of is and is not. A full regimen is not available. 3 meals a day. No more than 2 home delivered meals will be authorized for each day, with a maximum of 14 meals per week. A unit of service is a meal. The individual's ISP addresses how the individual's healthcare needs are being met, and services will be monitored by the support coordinator through the ISP to avoid any duplication with other services. The utilization of a home delivered meal may not occur if another paid or natural support is required during the meal. So the is and is not available only the community waiver, monitored by the support coordinator, up to 14 meals a week at a standard rate, is not authorized when natural support or paid supports is required during the meal, and is not authorized if the person has natural supports that can prep meals ahead of time for the person to warm up. In order to receive the service, there are some requirements or some skills the individual has to meet, as well as requirements for the provider. The individual must be able to prepare some or all of his or her own meals, but they will have to be able to warm up the meal independently if needed and feed themselves. And they must have no other natural supports to prepare their own meals and have the provision of home delivered meals delivered included in their individual support plan. For providers, providers must initiate new orders for home delivered meals within 72 hours of referral if specified in the ISP. They have to have the capacity to provide 2 meals per day, 7 days a week. They must be able to provide home delivered meals in accordance with each individual's ISP. And they must ensure that the meals served contains at least 1/3 of the current recommended dietary allowance as established by the Food and Nutrition Board of the National Academy of Sciences National Research Council. Shall provide menus to meet the particular dietary needs arising from the health requirements, religious requirements, or ethnic requirements of service recipients where appropriate, and must plan, prepare, and serve special meals for health requirements under the supervision consultation of a dietitian, and train the person responsible for the service of special diets to make appropriate substitutions based on food values. Right now, we have agency areas on aging contracted through Appendix K for this service. The service is open to all existing providers who can meet this need. Perhaps a day program who has a full kitchen can consult with a dietitian and deliver meals as prescribed. So there are some options for providers who previously didn't consider home delivered meals as being a possibility. And so with that, I'm going to pass that on the next slide to benefits planning to Dwayne Shoemate.
Thank you, Wanda. One of the primary concerns expressed by individuals, families, and public administrators considering employment has been the impact of public benefits. Previously, individuals could receive benefits planning services as a billable activity within career planning. However, this did not ensure information was being provided from a nationally certified and credentialed professional. As such, a new service definition of benefits planning has been added to the comprehensive community support and partnership waivers. This is a service based upon the analysis needed of an individual's specific benefits eligibility. Therefore, it is an individual service only with no group option. The service is designed to inform an individual about competitive integrated employment and assist them to assess if it will result in increased economic self-sufficiency and/or net financial benefit. The service does provide information available about work incentives that one may be eligible for as a recipient of supplemental security income, Social Security disability insurance, and also work incentives that may be applicable as a Medicaid recipient, Medicare recipient, as well as recipients of housing subsidies, food stamps, and ABLE accounts. There are several activities that can be included as part of the benefits planning service definition. These include income reporting requirements necessary for public benefits programs to include the Social Security Administration, working with an individual on formally developing a personal PASS plan, which is a plan for achieving self-sufficiency, or a PEST plan, which is a property essential to self-support. Assistance is also available in utilizing a variety of Social Security work incentives to coordinate Social Security and Medicaid work incentives that would support an individual, as well as providing assistance with individual benefit verification, consultation, education, and ongoing analysis and planning. This service is available for not just individuals who are employed, but also for those who are, one, may be considering employment and are early in the exploration of possibilities. Two, are actively seeking competitive integrated employment. Three, those who are considering career advancement, therefore increased work hours, wages, and new job goals. Or four, those who need problem-solving assistance to maintain employment, therefore when they're considering raises, increased work expenses, or similar other activities or impacts. The individual does not need to be present to deliver the service, as there are activities which include an analysis of earnings, review of benefits planning queries from Social Security Administration, and other activities. However, the service is only available when the individual has already attempted to seek support and services through a Missouri-based Social Security Supported Work Incentive Planning and Assistance Program, commonly known as a WIPA program. So the ISP must document that this service was not available, accessible, or applicable to the individual through the WIPA program prior to receiving the benefits planning service. Service is limited to no more than 60 units per annual support plan. Additional units may be approved by the division's regional director or designee in exceptional circumstances. This service is not appropriate for individuals who are not exploring, seeking, or maintaining or advancing employment. It's not appropriate for someone to simply report monthly earnings to Social Security or Family Support Division. And also the service must be delivered by a qualified provider, one who has a national credential or certification as outlined in the waiver application. The specific credential certification for a qualified provider are outlined in the waiver application. The sources of these credentials are from either Cornell University or Virginia Commonwealth University, as they are the only two national work incentive certification programs. The division is supporting capacity building by assisting with the cost of training at Cornell. If any participant in today's webinar would like to gain additional information about that, please contact your local regional office to learn more information. And with that, I will turn it over to Tanner Stevenson, our Director of Self-Directed Services.
Good morning. We will start with individual directed goods and services, often referred to as IDGS. IDGS is intended to allow individuals who self-direct their own budgets to purchase various needs, services, supports, goods that assist individuals in achieving their goals and outcomes that are specified in the ISP, all while reducing the need for or substituting for human assistance. These are the qualifications reported in the waiver. Each service, support, or good purchased by an individual must meet the individual safety needs, community membership, and advance the desired outcomes in the ISP, increase independence, reduce the need for a Medicaid waiver service, have documented outcomes in the ISP, not be provided by federal, state, not be prohibited by federal, state statutes, regulations, not available through another source, and the individual does not have the funds to purchase it themselves. It must be acquired upon anticipated use in most cost-effective methods, whether that be purchased outright or a lease, and it must not be experimental or prohibited. The maximum amount that may be allocated toward IDGS is $3,000 per annual support plan per year. This must be accommodated within the individual's budget without compromising the individual's health or safety. And I will now pass it on to Ree for intensive therapeutic residential habilitation.
All right, so intensive therapeutic residential habilitation service is a short-term integrated treatment service. It's new. It follows an integrated team approach with a focus on building safe community skills when all other methods have failed in the past. Next slide, please. Back one slide. Okay, so this service is meant for people who have tried less restrictive supports in the past, and those supports have not worked out. It's for folks that need longer, more intensive integrated treatment so that they can learn skills that will help them return to a less restrictive community setting. Next slide. So how you would go about requesting this service is the service coordinator would put in a UR request, and the chief behavior analyst or area behavior analyst will help determine if medical necessity is met at the time of that UR request, because not everyone meets criteria for medical necessity. So that need needs to be established as part of the person-centered planning. The service is meant to be short-term, not a forever home or service, and so up to 12 months is typical, but it may be extended on a need basis. We also ensure that there's careful monitoring and extra transition support when individuals graduate from the service and are ready to go back into a less restrictive community setting. And then who can provide this service? So providers that are contracted via waiver that also maintain status as an active tiered support agency. So not every provider can provide this service. It's got to be approved by the chief behavior analyst or their designee, and they need to meet the ongoing requirements of having a clinical director that has graduate level training in applied behavior analysis or another division approved evidence-based intervention. They also need to have, that clinical director needs to have 3 years of experience delivering services to people with dual diagnosis and high-risk behaviors, and then 3 years of experience participating in an integrated clinical team. And then oversight of the service provided by the clinical director and support staff would be done by the division. And the clinical director needs to participate in at least annual performance appraisal by the chief behavior analyst or their designee. And now I'm going to pass it off to Shelley Brown, the PR specialist for Universal Design.
Okay, good morning. Just wanted to go through a few of the changes that are going to be impacting EAA services. Hopefully this will be able to provide some ease in the requesting portion of that, as well as provide additional options for families and individuals to use. So on the current slide, we do have what is currently listed in the waiver as exceptions, or I'm sorry, as exclusions to the service, and those are going to continue as is. So adaptations or improvements to the vehicle that are of a general utility are not direct medical or remedial benefit to the individual.
Shelley, I'm going to interrupt you for just a moment. We have folks saying that they can't hear, so if you could speak just a little bit louder, I think that would be helpful.
Okay, is this better?
Yes, that's a lot better. Thank you.
Okay, my apologies. So let me kind of start over real quick. Just wanted to review a couple of changes that are going to be occurring that are specific to EAA services. And these are hopefully going to provide some ease in the requesting of services, as well as provide some additional options for family members and individuals to utilize. So what we have on the current screen is the vehicle adaptations that are excluded in the waiver, and these are going to continue as is. So adaptations or improvements to the vehicle that are of a general utility are not of direct medical or remedial benefit to the individual. Waiver will not provide purchase or lease of a vehicle, nor will the waiver regularly scheduled upkeep and maintenance of a vehicle, with the exception of upkeep and maintenance of the modification will be considered. So on the next slide, we'll go into a little more detail in regards to some changes in vehicle use. Currently, we don't have an option for the purchase of an existing adaptation in a pre-owned vehicle, but the language change will allow this in instances where the vendor, the contracted vendor, would be paid directly by the state. The individual will not receive any direct Medicaid funding for the purchase, but as stated before, this will be directly to the contracted provider. That contracted provider must provide an invoice that includes not the vehicle costs, but only the modification cost. And the price of the adaptation must be comparable to market value and not include any labor cost, which goes back to why it's already an existing adaptation in a pre-owned vehicle. One exciting piece is that at this time, the 7,500 limit has been modified to the 10,000 without the use of an exception. So you should be able to access the maximum of 10,000 without going through the exception process. So we'll go a little more detail and give some examples on the next slide. Again, waiver funds cannot be used for the purchase of the vehicle or the chassis. So, for instance, family members may make full arrangement for payment of the vehicle. They may be doing payment options for that vehicle. But again, the use of waiver dollars would only be for the adaptation. Some examples of things that could be utilized as a resource to establish that vehicle cost would be the Blue Book. So utilizing Blue Book value to determine the vehicle cost without modifications is something that is recommended and allowed to be utilized in that service. Next slide is going to give a little more example. For instance, if the modified vehicle price from that contracted provider is $25,000, Blue Book or another similar resource gives the vehicle value of the unmodified vehicle at $20,000, we can determine that the waiver funded amount for the modification is at a $5,000 cost. It is that $5,000 that will be directly paid to that contracted vendor to pay for the actual modification cost. So those are a couple of changes. Hopefully those will provide some ease in utilizing the service, and we'll go ahead and turn this over to the next presenter.
Good morning. This renewal for assistive technology sees a complete revision of the assistive technology definition in an effort to truly define what it is, how it is used, and the components of the service. As a technology-first state, the planning team should always consider technology solutions to meet a person's need before considering in-person supports. Assistive technology is now part of every person's daily lives and has the means to improve independence, vocational skills, community involvement, mitigating isolation, and improving people's overall life satisfaction and realizing true independence and privacy. If you take away only one thing from these assistive technology slides, please take away a philosophy and belief that all people should be afforded the same technology benefits as you or I, and that while we might take those things for granted, the people we serve use them as vital tools to their daily lives, and we should facilitate that level of independence to the best of each person's ability. The waiver cap for assistive technology is still $9,000. All 4 of the new components must fit in within that cap. This means that the response centers for remote supports currently authorized as personal assistants will have to be converted to the Remote Support Service Code. Amendments and renewals to plans implementing the service definition change must be completed no later than September 24th, 2022. We had not anticipated CMS requiring us to remove the response center from the remote support services. This will make many people exceed the cap. The division will be considering options such as separating remote support from general assistive technology definition. Please remember, as you move forward in exploring technology as a solution, for you and I, technology makes daily life and independence easier. For the people we serve, it makes things possible. So, who can do assistive technology? The consultation component may be provided by a person with a Missouri license in occupational therapy or physical therapy, or speech and language pathology, an assistive technology professional certification issued by the Rehabilitation, Engineering, and Assistive Technology Society of North America, or a bachelor's degree and a certification from a nationally recognized assistive technology assessment curriculum, such as SHIFT or a college program, or have a bachelor's degree considered a specific technology expert as employed by a technology-specific provider for at least 1 year. Consultation is a new part of the definition. The billing codes for assistive technology are broken into 5 components, which are listed on the next slide. Consultation will have a modifier of UA, equipment UB, service delivery UC, support U9, and all 4 components will have the modification of GT. Each component is given a modifier so we can pull reports and determine which components are being used and how widely they are being used. This is part of our technology first data collection efforts. Planning activities should include the exploration of technology solutions whenever possible, providing opportunity for discovery and implementation. Assistive technology consultation means an evaluation of the assistive technology needs for an individual, including functional evaluation of technologies available to address the individual's assessed needs and support the individual to achieve outcomes identified in his or her individualized service plan. 1 per year is the max. An exception may be extended if the person is pursuing new or additional types of technology. Assistive technology equipment means the cost of leasing, purchasing, warranty at purchase, or otherwise providing for the acquisition of equipment that may include engineering, designing, fitting, customizing, or otherwise adapting the equipment to meet the individual's specific needs. Assistive technology equipment may include personal emergency response systems, also referred to as PERS, mobile emergency response systems, known as MERS, and medication response systems. The acronym for that is MISS, but it's an MRS. The equipment used for remote support, such as motion sensing systems, radio frequency identification, live video feed, live audio feed, or web-based monitoring. Assistive technology cannot be accessed to purchase video monitors or cameras to be placed in bedrooms or bathrooms. Remote monitoring and placement of cameras in bedrooms and bathrooms are not allowed. Assistive technology service delivery means monthly implementation of service or monitoring of the technology equipment and individual as necessary. Monitoring may include the Response System Center for MERS, PERS, or remote supports. Assistive technology support is intended for education and training beyond what is included in the initial installation and training or routine service delivery questions and implementation that aids the individual in use of the assistive technology equipment, as well as training for the family members, guardians, staff, or other persons providing natural supports or paid services employ the individual or who otherwise are substantially involved in activities being supported by assistive technology equipment. Assistive technology support may include, when necessary, coordination of complementary therapies or interventions and adjustments to existing assistive technology to ensure ongoing effectiveness. Next slide, please. One more slide, please. Planning and activities should include the exploration of technology solutions whenever possible, providing opportunity for discovery and implementation. All technology promotes independence and self-reliance. Remote support, more than any other technology, builds confidence, which decreases people's reliance on paid staff for activities in the home and in the community. While these things might seem new to some of you, the newly designed Universal Design and Assistive Technology team is working to bring you additional resources and training opportunities. So please stay tuned as we bring those to you. I will now pass it on to Ree.
So we had some changes to the community transition service definition. We revised the first paragraph of the definition to incorporate CMS requirement It now states community transition services are non-reoccurring setup expenses for individuals who are transitioning from an institutional or another provider-operated living arrangement to a living arrangement in a private residence. Those provider-operated living arrangements are provider-owned residential settings where Mo Health Net reimbursement is available. It includes the following: intermediate care facilities for individuals with intellectual disabilities, nursing facilities, residential care facilities, assisted living, and DD waiver group homes. The two bullets, expenses to transport furnishings and personal possessions to the new living arrangement, were combined to say essential household furnishings and moving expenses required to occupy and use a community domicile. We adjusted language in the first sentence under limits section. We replaced the waiver with a living arrangement in a private residence. And then under allergen control, we added the assurance only to be rendered when the allergen control addresses the individual's disability who demonstrates a need for allergen control. And then we added a couple of items. So allowable expenses, under allowable expenses, we added internet service setup. So allowable expenses are those things that are necessary to enable a person to establish a basic household that do not constitute room and board. They include things like essential household furnishings and moving expenses, security deposits in order to obtain a lease, utility setup fees, health and safety assurances, and things like allergen control. And now internet service setup was added to that. And then for the exclusion list, we added TV service or media players were added to the essential furnishings exclusion list. Clothing was proposed to be included as a recommendation from the SAT work group. However, CMS required it to be removed as it is not an approvable item. And now I'm going to pass it back to Wanda.
So in-home respite care is provided to individuals unable to care for themselves on a short-term basis because of the absence or need for relief of those persons other than paid caregivers normally providing the care. The italic language is the revised service definition. So those persons other than the paid givers is revised, and as is the last sentence, respite care may not be furnished for the purpose of compensating, relief, or substituting staff. In our prior language, we said provided in the individual's place of residence or in a licensed, certified, accredited facility when service is provided for interim periods. And it said that overnight care must be provided in the individual's place of residence. The current language says the service is provided in the individual's home or private place of residence. So a little bit of change of distinction there. As we move on to different kinds of respite, examining out-of-home versus in-home, again, the italics being new, out-of-home respite is short-term basis due to absence or need for relief of those who normally provide care for the individual. It is provided outside of the person's home, must be short-term. Statement has to be identified as a need in the ISP and provides planned relief to the customary caregiver and is not intended to be a permanent placement. While the limit remains mostly intact from the previous waiver, CMS did ask us to insert a hard limit to the exception amount by adding this language. So our current limit says no more than 60 days annually unless an exception approved by a ROD or designee being new. If provided in ICF ID or state HAB center, cannot exceed 30 days. CMS asked us to add a hard limit of total limit of out-of-home respite is 6 months. The out-of-home respite service is a temporary service and requires a hard limit to the exception amount, and this would not affect the other sections. So as we were going through the waiver renewal and through previous service advisory teams, we did hear from individuals and families, support creators and providers that we don't have enough resources to provide the out-of-home service, that locations were limited, few and far between, sometimes used, termed into permanent placement instead of respite beds. So we added additional eligible locations to the waiver based on that feedback. Previously, you had to use a licensed community residential facility or a state-operated ICF IDD. We revised and added additional locations to include shared living host homes, shared living relief homes, and standalone respite facilities. So that's quite a nice expansion. We'll talk about a little more detail on the next slide. So even though, as we've expanded, the italics are new language, standalone respite facility still has to be certified or accredited. Licensure and certification will be amending applications and developing new processes around the standalone facility. So we do have a certification process for that. The caveat surrounding host home providers is that they may not provide out-of-home respite services if there is currently an individual living in that home and receiving host home services. So the host home shall not provide out-of-home respite if there is an individual currently residing in the home and receiving host home services. So we'll move on to personal assistant. The core service definition is not changed. It includes a range of assistance to enable the individuals to complete tasks they are not able to do for themselves, provide supports and incidental teachings to assist the person to participate in their home and community, and can be provided in the person's home, family home, and in the community. A few reminders about personal assistance. It is always performed in the presence of the person. Staff are not eligible to sleep during the service provision. It is limited to additional services not otherwise covered by state plan. So you must always source state plan or other resources before accessing the waiver. The team collaboration component specifically applies to self-directed services, and the sentence is replacing up to 120 hours per plan year to limited to 120 hours per plan year. Just a small distinction that was made in the definition. So we were very successful and able to retain the Appendix K hospital support component in the waiver service definition. So very exciting that we were able to do that. The hospital support component of personal assistant has to be identified in the person-centered service plan, provided to meet the needs of an individual that are not met through the provision of hospital services. It is not a substitute for services that the hospital is obligated to provide through its conditions of participation under the federal or state law or under another applicable requirement, and be designed to ensure smooth transitions between acute care settings and home and community-based settings, and to preserve the individual's functional limitation. So there, just a few little points, very defined. It cannot be used as a substitute for hospital obligations. It is also not used for simply visiting, simply checking in. You have to clearly define what the purpose of the personal assistant is in that hospital, and that it serves a function, a purpose, and that the hospital cannot provide. Hospital supports under personal assistance are billed to the same personal assistant code and the existing authorized rate already authorized in the person's ISP with personal assistance. So no special code for personal assistance. So there are some changes to the service definition that we all need to be aware of. People who are currently receiving group home, which includes semi-independent living centers, individualized supported living, or shared living services can no longer receive personal assistance as an additional service. This is due to the fact that both group home, ISL, and shared living definitions contain personal assistant components. The residential services are required to meet the personal assistance needs of the individual through that service definition. So how we're going to work with that, everyone I know is asking. So we have 365 days from approval or till September 24th of 2022 to make amendments or renewals to the plans that currently have personal assistant authorized in addition to group home or ISL or shared living services. So you can change it tomorrow, you can change it 2 months from now, you can change it 4 months from now, but it must be changed no later than September 24th of 2022. Additionally, CMS had us make another change, and that is that personal assistance can no longer be authorized for the purpose of a remote support response center. CMS felt that using Group PA for remote support response centers was a duplication of the intent of the assistive technology service. They saw it as a direct component of remote support and should be billed to assistive technologies. So providers who have been billing PA for the purpose of response center will need to work with the planning teams to remove the remaining authorizations for the people's ISPs to the assistive technology remote support specific code of A9999GT. So all components of remote support are authorized to the A9999GT. The remote support or the technology component, the response center, and all 4 of the components that Holly talked about earlier, the consultation, the follow-up, anything related to remote supports gets billed to the A9999GT code. So we had sent an email out to our assistive technology providers providing remote supports to give them a heads up about this change. And to those community support providers that we know had developed or were in the process of developing a response center. So they would know that this was coming and so they could start working on it. What we know now is we also have a transition period of no later than September 24th, 2022 to make these changes. So we wanted to get you the heads up, but we've only recently realized that we were going to allow a time period to achieve these changes. So again, just like the other PA change, you can change this next month, 4 months from now, but no later than September 24th of 2022. So moving on to group home services. Group home services core definition has not changed. The group home services provide care, supervision, skills training, and activities of daily living, home management, community integration, includes assistance and support in the areas of self-care, sensory and motory development, interpersonal skills, communication, community living skills, mobility, healthcare, socialization, money management, and household responsibilities. A few minor changes in the language were made, referencing instead of groups of recipients, it's individuals who live in, to represent more person-centered language in the service definition. Language was added to emphasize the home and community-based service rule around group homes being provided by provider-owned, controlled, and therefore must ensure compliance with the HCBS rule. We also wanted to make sure that people realize and understand that transportation is a component of the group home service. It is included in that daily rate. And I think we defined in that definition some differences there. So to provide some more clarity, things we've always done, but just some clarification. So the transportation included in the group home daily rate includes non-medical transportation, access to the community. Their additional transportation may be authorized to access work and day habilitation programs. And the transportation service the transportation component of the group home is responsible to ensure medical transportation is billed to state plan. So those are kind of the three breakdowns of transportation in a group home. Group homes definitely responsible for non-medical transportation into the community. They can access transportation for outside of the group home for day program work purposes, but the group home cannot bill transportation for medical purposes. That has to be billed to state plan. Again, just to re-emphasize how lucky we are to be able to retain the hospital support component that we had temporarily approved through Appendix K. We were able to keep that as a component of the group home service as well. This service component of hospital support is identified in an individual's ISP, provided to meet the needs of the individual that are not met through the provision of hospital services. They are not a substitute for the services that the hospital is obligated to provide. And they are designed to ensure smooth transitions between acute care settings and home and community-based settings, and to preserve the individual's functional abilities. Again, very specific, cannot replace the responsibility of the group homes, and you cannot use it for the purpose of visiting, checking in, making sure they're okay. It has to be clearly defined in the ISP and have a distinct purpose. When a person receives a group home and also receives hospital supports, the group home will reflect an absent in Seymour and not bill for that day. The supports identified in the ISP are billed to a separate code under S5125HI at $7.27 a quarter unit. We had previously referenced this when I talked about personal assistance, but it's always worth just kind of bringing it home everywhere that the impact applies. In the group home, again, CMS read our language, and the components of personal assistance are included in the group home. If you reflect back to the first slide I read you about a group home's responsibility, it includes socialization and community access. Therefore, the group home service includes components of personal assistance, individual skills development, and community networking. Therefore, neither PA, ISD, or community networking services can be authorized it cannot be authorized in addition to group home. So a person receiving group home services can no longer receive personal assistance, ISD, or community networking as a separate billable service from group home. CMS made us add the specific language that these PA, ISD, and community networking are already components of the group home service and funded under the group home service definition. So alternatives to the group home combination of PA, ISD, and community networking, alternatives are employment services, day habilitation services, or receiving those community services at home from the day program, at home from the group home during the day. So just as the other services we talked about, any amendments or renewals to the plans implementing the change, removing authorizations for PA, ISD, and community networking from people who also receive group home services must be completed no later than September 24th, 2022. So likewise, we had a few minor changes in the individualized supported living definition. Language was added to the definition to emphasize individualized supported living reflecting 4 principles: community membership, self-determination, rights, and basic needs. So ISL is delivered as personalized manner to individuals who live in homes of their choice. They may choose with whom and where they live and the type of community activities in which they wish to be involved, characterized by creativity, flexibility, responsiveness, and diversity, and enables people with disabilities to fully integrate in communities. Clarifying language: the home in which a person receives ISL service is a private dwelling, not a licensed facility, and must be owned or leased by at least one of the individuals residing in the home, and or by someone designated by one of those individuals, such as a family member or legal guardian. Each individual in the home has free choice of provider and is not required to use the same ISL provided by their housemates. The second bullet is a philosophy and practice the division has supported for many years, and we've updated our definition to match that philosophy and practice. Just like personal assistance and group home services, we were able to successfully retain the hospital support component currently available in Appendix K as a component of the ISL service. Again, it may be provided in hospital supports to assist with supervision and communication and transition, and other components that the hospital is unable to provide or not required to provide. It must be identified in the person's ISP. It is not used for visiting, checking in. It must be clearly defined as how the function is working with the person. Like group home, hospital supports are billed to a separate code. So the ISL provider in their billing for the T2016 ISL code bills absent for the days that the person's in the hospital. But if they use hospital supports identified in the ISP, they bill to the S5125HI at $727 a quarter unit. Just as in the group homes, the new limitation related to personal assistance, individual skills development, and community networking, that limitation also applies to individualized supported living. Now, we did pull a report last week, and from preliminary data, we do not have any individualized supported living also authorized in conjunction with personal assistance or ISD. So we're still pulling and finalizing that data, making sure that we've captured everyone and all the current authorizations, but it's looking relatively clean with the ISL service definition. PA, ISD, and community networking are already components of the ISL service and funded under the ISL service. So again, if we do come across any combination of PA, ISD, community networking authorized in addition to ISL services, those have to be modified and the appropriate service selected, whether that's day habilitation, employment, or additional ISL hours. They have to be adjusted no later than September 24th of 2022. Shared living. So our core definition has not changed: an arrangement in which an individual chooses to live with a couple, another individual, or family in the community to share their life experiences together. Shared living can be provided in the home of a caregiver or a host, or in the individual's home, in which case it's a companion. Shared living includes skills development to prevent the loss of skills and enhance skills leading to greater independence and community inclusion, and transportation is included in the shared living rate. While the shared living service is oftentimes the experience of belonging to a family, there are service expectations in that living arrangement, which include supporting people to develop skills. New language was added to the service definition to state what is already included in the budget development that transportation is included in the shared living rate. Again, just as in PA, group home, and ISL, we were able to retain the ability to use hospital supports as a billable service for people who are in the hospital and receiving shared living services. Just as the other service, this is for components that the hospital is unable to provide or not required to provide by their regulations, must be identified in the ISP as a distinct service, not visiting or checking in, clearly defined as what the staff are going to be provided and how it's not duplicative of the hospital service. In this instance, the shared living provider will still reflect an absence in Seymour related to the shared living billing. Instead, for hospital supports, they will also bill the S5125HI at $7.27 a 15-minute unit. While shared living is a home with a family or other individuals, and the host or companion has always been expected to provide personal assistance, skills development, and community integration. It's always been a component of that service definition. Therefore, people receiving personal assistance, individualized skills development, and community networking can no longer also receive shared living. The combination of services is a duplication of the core shared living definition. Therefore, people who currently have these services authorized as a combination need to have their plan reviewed and assessed for what the person's needs are and what is the appropriate replacement services. Again, is that day habilitation? Is that employment? Is it staying home with their host or home with their companion or home by themselves? So again, all modifications or renewals to the plans implementing the removal of the duplicate services must be completed no longer than September 24th, 2022. And with that, I am going to turn it back over to Dwayne Shoemate to talk about community networking.
Thank you, Wanda. Community networking, previously known as community integration, is an individual or group service that is in the comprehensive community support, partnership, and MOKID waivers. The group size cannot exceed 4 individuals per staff person. Individuals are to be supported in the setting which aligns with their skills, abilities, and optimizes their autonomy and independence. The name was changed to clarify the intent of the service. It is not just to be in the community, but to support individuals for value and active participation in integrated activities. The outcomes are for individuals to participate in and choose activities that build social relationships, community involvement, and membership that builds upon the individual's interest, preference, gifts, and strengths. Clarification was also added that the expectation is to decrease supports and transition to natural supports when possible. To afford greater flexibility and individualization, the service limit has been revised to a monthly amount of 432 units, which is 108 hours. In addition, clarifying language was added that activities related to community service, commonly called volunteering, are allowed for personal leisure and preference as part of community networking. However, if the person is volunteering for purposes of working on employment pathways, then the appropriate service would be pre-vocational services. So again, community service is okay as community networking, but if one's volunteering as part of an employment pathway, then that service should be pre-vocational and not community networking. Okay, moving on to individualized skills development. It is an individual or group service that is in the comprehensive community support, partnership, and MOKID waivers. The group size cannot exceed 4 individuals per staff person. Individuals are to be supported in the setting which aligns with their skills, abilities, and optimizes autonomy and independence. Clarifying language was added to reflect outcomes for individuals to learn specific skills necessary for independent living. Clarifying language was also added to indicate that it is for individuals who live in their own home or their family homes. As Wanda indicated earlier, ISD is not available to individuals in shared living, ISL, or group home. Service limits have also been revised to a monthly amount of 348 units. An addition was also added for ISD as required from CMS to indicate that services are limited to those not otherwise covered under the state plan to include early and periodic screening, diagnosis, and treatment. This is consistent with the waiver objective of avoiding institutionalization. Lastly, ISD was updated to include the language included within Provider Bulletin number 25, Volume 1 on credentialing requirements. Essentially, what was completed was a deletion of previous language regarding state credentialing process, and it was replaced with successful completion of the coursework as identified in this Provider Bulletin, which is systematic instruction training through either Reliance Learning or College of Direct Supports. Moving on to day habilitation. Day habilitation is a service, again, that continues to be available in Comprehensive Community Support Partnership for Hope and the Missouri MoKids waiver. Language was revised to reflect that services are designed to assist individuals to acquire, improve, and retain self-help, socialization, and adaptive skills that enhance social development and develop skills in performing activities of daily living and community living. Services may also be provided to support retirement activities, and this was a new language to ensure that we're working with individuals across the entirety of their lifespan. Activities and environments language was added to reflect that activities and environments are designed to foster the acquisition of skills, building positive social behavior and interpersonal competence, greater independence and personal choice. Activities should be appropriate to the setting and occur in the most natural setting possible for the individual. So again, if an individual is just attending activities in the community as part of DayHab, that is wonderful. If we're working on individualized goals around value-added integration and true community membership, then that would be community networking. Lastly, with day habilitation, the medical exception language was revised. Documentation required for requesting, reviewed, and approval by the UR committee. What is required is a written support plan, which includes clinical outcome data with criteria for reduction of supports if relevant to the identified medical condition. The word if replaced what we previously had in there, which was the word as relevant. In addition, written documentation noting the individual's assessed need for medical or mobility supports is required from the individual's medical practitioner. Also, in DayHab, behavior exception language was revised to indicate that people with exceptional behavior support needs may be granted a behavior exception when additional staffing is required to keep them and or others safe. Requests for behavioral exception shall be submitted to the UR committee and include one of the following types of documentation. An ISP inclusive of a behavior support plan, including supports to be implemented through the day habilitation service and confirmation of ongoing applied behavior analysis services, or an approved ISP documenting behavior supports have been recommended. So those are the new language that was added for the behavior exception. As we move on to career planning is an individualized service that is in the comprehensive community support and partnership waivers as it has been in the past. Language was updated to reflect national best practices to include discovery and customized employment, which is the person-centered approach to supporting individuals with intellectual and developmental disabilities. Language in the definition clarifies that the rates are included for the implementation, therefore the delivery of the service, but are not included to get someone to and from the service provider. Embracing the division's Tech First initiative, an additional billable activity was included for the employment support professional to be exploring and assisting the individual with considering what types of apps or general technology could be utilized to assist them in overcoming potential barriers in future work settings or work pathways. Although previously required, the expected outcome of a career plan at the completion of career planning was further clarified. Upon completion of the service, the provider must complete a career plan, sometimes known as a discovery profile, which will guide the planning team and the individual on the future employment supports and services that are needed. This must include a career path, which is a job goal or a job theme. As an example, warehouse worker, stocker, secretary, health occupations, etc. But the job goal needs to be specified with an indication of what the individual's desired amount of work hours and work income is upon completion of the service. The plan must also identify needs, the individual's strengths and considerations of natural supports, and the potential work environment needs they have. The plan must specify the actions needed to achieve those goals. So this will really help the support coordinator and the individual in knowing what type of additional supports and services may be needed upon completion of the career planning service. An additional training will be delivered in the future by the division on these outcomes and reporting requirements. Earlier, we talked about there being a new service definition for benefits planning. As the benefits planning service was added to the waiver, we did remove language around billable activity on Social Security benefits support, training, consultation, and planning. Informal discussion related to asset development is a billable activity, as is the determination and coordination of specific work incentives. That would require the benefits planning service definition. So just the informal discussion about one's ability to work, the informal discussion about the ability to have earned income and retain benefits, those are still discussions that can occur as part of career planning and also continue to be billable activity. But if we are working on specific work incentives, requesting benefits planning queries to assist the individual in determining the exact amount of income, that type of benefits analysis and planning should be occurring in the benefits planning service definition and not in the career planning service definition. As we move on to job development continues to be an individualized service that's available in the comprehensive community support and partnership waivers. Language is updated here as well to reflect national best practices of person-centered approach to job development for individuals with intellectual and developmental disabilities. Language in the definition clarifies that the rates are included for transportation as part of the delivery of the service, but are not included to get someone to and from the service provider. Also, similar to career planning, to embrace the division's Tech First initiative, an additional billable activity was included for the employment support professional to also be exploring and considering how assistive technology or apps could be utilized to assist the individual in future workplace sites and to secure potential employment. Moving on to the next slide, similar to career planning, language was added on the expected outcome at the completion of job development. Upon completion of the service, the provider must complete a job retention plan, which will guide the planning team and individual on future employment supports and services that may be needed. This must outline the job title of the secured employment position, the wages, projected average number of hours worked weekly. Also, the job plan should include the implementation strategies for paid and natural supports regarding any unmet needs that the individual may have in the work setting. Again, additional training will be delivered on these outcomes and content of these plans. Supported employment continues to be a service that is available as an individual or group service in the comprehensive community support and partnership waivers. Not unlike previously, the group size cannot exceed 4 individuals per staff person. Individuals are required to be supported in the setting which aligns with their skills, abilities, and optimizes autonomy and independence. For those who receive group support employment, there continues to be the requirement that this be reviewed annually to determine if the person could transition to a more affirmed and optimized individual setting. New language was added indicating billable activity to include assistance with just reporting and managing earnings with Social Security and Medicaid. For anybody who is a Social Security recipient or Medicaid recipient, there is the requirement to be reporting monthly earnings. Just that simple reporting of earnings to Social Security is a billable activity and supported employment. This is simply the process of reporting and not doing formal benefits planning. Again, if someone's looking at formal benefits planning of utilizing work incentives, considering changes to their Medicaid eligibility type, then those types of activities should be completed in the benefits planning service definition. Similar to the other employment services, language was added around an expected outcome of support employment. That outcome is sustained employment at the end of each month. Upon completion of the service, at the end of each month, the provider must complete a retention plan for the upcoming month, which again will guide the planning team and the individual on what ongoing employment supports and services they might need. This must include a description of the results of the observation and assessment that has occurred throughout the month on the work site, as well as what ongoing paid and unpaid supports may be needed. It also includes a summary of implementation strategies which are necessary to maximize employment independence, natural supports, job performance, and identification of any potential risks. Similar to the other employment definitions, there will be additional training about these plan requirements and outcomes. Pre-vocational is an individual or group service that continues to be in the comprehensive community support and partnership waiver. Not unlike employment, group size continues to be limited to 4 individuals per staff person. Individuals, again, must be supported in the setting which aligns with their skills, abilities, and optimizes autonomy and independence. Language was added that clarifies that volunteering as part of pre-vocational is for employment skill development. As I noted earlier, if someone's simply volunteering at what we will call community service for personal avocation reasons, then that can be community networking. But if an individual is volunteering as part of an employment pathway or to learn skills necessary for employment, that should be being completed underneath the pre-vocational service definition. In order to afford greater flexibility, the previous weekly service limits were removed and replaced by allowing the same number of units to be delivered over an annual plan year. So there is no reduction in the amount of units. All we've done is simply remove the weekly limits and enable providers to deliver up to 2,080 units per annual support plan year. New language was added also to allow for billable activity to consider the use of assistive technology or apps in helping the individual to become more independent in their pursuit of employment. Also, informal discussion just related to asset development and financial literacy can be completed as part of pre-vocational, as long as it's not about looking at actual work incentives and coordinating those work incentives. If that's the level of formal discussion that needs to occur, then again, that should be requested as part of benefits planning, which could be occurring concurrently with pre-voc, career planning, or support employment services. Language is added on the expected outcomes of pre-vocational, which is progress of habilitative skills necessary for employment. Upon completion of the service, at the end of each month, the provider must complete a plan that reflects progress towards the skills being developed and ongoing development activity for the upcoming month, which will guide the planning team. So if an individual has a specific skill that they're working on related to accepting supervision, there needs to be clear documentation on what the skill being developed is, how it's going to be developed, and the progress towards that development. Additional training will continue to be provided by the division on these outcomes. As you have noticed, each of the employment services have added outcomes, which were recommended by the Employment Services Advisory Team. These outcomes help clarify progression through services, inform the individual and planning team on specific supports being delivered and needed, and will assist with ongoing future data collection and reporting, which will assist the division in beginning to explore value-based purchasing in the future. And with that, I will turn it over to Kim Stock.
Few updates in regards to professional assessment and monitoring, or PAM, as we know the service. For these slides, you'll note that we're highlighting the revisions or changes in red font. As a reminder, professional assessment and monitoring, or PAM, is intended to promote and support an optimal level of health and well-being. New language has been added that indicates a prescribing practitioner must prescribe an identified need for the PAM service. The intent of this is to support individualized planning and support the team to identify what the specific purpose for PAM is necessary for to enhance and promote health and well-being of the individual. An example could be for support of chronic disease management or in response to an acute healthcare change in status. Additional language again under the new service, under the service definition under scope. As a reminder, the service must not supplant Medicaid state plan services or Medicare services for which an individual is eligible. Excluded services include diabetes self-management training and available under the state plan and medical nutrition therapy services prescribed by a physician for Medicare eligibles who have diabetes or renal diseases. The new language is PAM is not continuous care. As a reminder, the intent of PAM is a consultative service. With PAM being consultative in nature, as we've highlighted here, it's a service that is by a licensed healthcare professional that may be utilized to assess, examine, evaluate, and or treat an individual's identified condition or conditions or healthcare needs and planning, and may include instruction and additional information. The statement was changed from training when indicated to training when identified as needed for the care of the individual. Next slide, please. The state revised the following statement, again, under the service definition scope. From, this would include but is not limited to reporting all changes in health status to the physician and the support coordinator and providing written reports of the visit to the support coordinator. This language was changed to, all changes in health status are to be communicated to the physician and the support coordinator. Written reports of the visit will be provided to the support coordinator. All services must be documented in the individual record. The state revised the first sentence after EPSDT to include the following language, but consistent with waiver objectives of avoiding institutionalization. Next slide, please. And with that, we'll be turning it over to Tanner Stevenson, who will be speaking to updates in regards to community specialists.
Thanks, Kim. The service definition of community specialist has been enhanced to include the following text that you see on this slide. The enhancement of the definition is aimed at further preventing the service of community specialists from duplicating other supports or services provided by other means, by suggesting that a community specialist may require the needed experience and skills to provide direct instruction to individuals that assist the individual in achieving their outcomes. The waiver has been updated. What you see at the top of this slide is what was previously reported as the provider categories and provider types that could provide community specialist services. It was thought that the language reported on the top of the slide limited the type of providers that could offer the community specialist services. So the waiver now reports what you see at the bottom of the slide, which will allow any provider with a DMHDD contract who has a qualified staff to provide the community specialist services. This is another change within the waiver for support brokers. The scope of support brokers is enhanced to include IDGS, as we discussed earlier, as an item that support brokers are permitted to provide information and assistance with to individuals or designated representatives. Another change within the support broker service is just a rearrangement of this requirement. The requirement that the support broker have experience or Division DD approved training is no longer referenced in the definition or scope of the support broker, but is now referenced under each provider type, the verification of provider requirements. So this, again, is just a rearrangement of the requirement, and no changes should be recognized. And I will now pass it back to Ree for crisis intervention.
All right, so we have some changes to the language in the crisis intervention service. As you can see on the text on this slide, the takeaway points from this is we wanted to clarify intent of the service. Both the availability and location have been clarified here, and that the service must be available to the individual at any time of day during the approved dates of service, and it may be provided at home while also being provided in a group home or ISL setting or shared living services somewhere else in the community. The key takeaway points from the language change on this slide is we made it clear that there should be a written crisis plan when this service is being used. And we also added that there must be monitoring of the fidelity and efficacy of the service so that adjustments can be made to interventions as necessary. Here we revised the service limits to be unit-based rather than time-based within a plan year. So we defined temporary instead of being 4 to 8 weeks maximum. We now defined it as not to exceed 2,920 units per individual per waiver year. This should allow for greater flexibility in the services used. And then this is continuation of the clarification from the previous slide. So again, we clarified this to be unit-based rather than time-based, and that it could be 24-hour care in a crisis bed of a resident. Here we clarified qualifications of the service team to be that there must be a crisis professional that provides clinical oversight of the service, and there also must be a crisis technician. And then we had some minor changes to the applied behavior analysis service. The primary changes for individuals that are hospitalized, we clarified to where applied behavior analysis services can be provided in a hospital whenever the hospital cannot meet the need and whenever a hospital can't meet the person's behavioral need, and also to allow for a smoother transition back to a community-based setting. Again, like our other waiver services, this is not a substitute for services that the hospital is obligated by law to provide. And now I'm going to turn it back to Emily.
I want to thank everybody for joining today. I know there was many questions in the chat, posted today in the chat, and we will be pulling those together and creating the answers for those questions and providing a Heike, I'm not sure, is that going out by email and a blast with that information?
So what we'll do is we will post that question and answer document along with the recorded webinar and presentation on our previous webinar page. Again, the recording will go out this afternoon, but that Q&A document will likely not go out for several days to ensure that we get complete answers to all of your questions. So when that becomes available, we will send out an email blast from the division letting folks know that that is now available. So be watching for that to come via email blast.
Sure, thanks, Heike. Just a reminder that the slides are available on our website, the updated ones that you saw today. And there is a programmatic change document that goes through the high-level changes for each of the services. And as I mentioned earlier, there will be some more communication about the transition period. Wanda hit on some of those transitions today in our training. There'll be a memo or a letter sent out about that transition period, just as a reminder for those services that have a transition. And then we'll be working on your question and answers. So we really appreciate your time today. And I know as you're implementing changes, you'll have more questions, and our resources, our regional offices are out there to help, as well as FPU and the whole division. And that's all I have. Thank you for attending.